Hello. I see you.
Somebody's talking to me.
Maxie, right?
Was testing my mic. Thanks.
Oh, yeah, we can hear you. How are you?
I see Maxie as well, yeah.
Okay.
And Clarence and you, Diana, and Megan.
Okay, I think that's and yourself. That's all that's here so
Yeah.
far. Well, here comes Bill. Can you see Bill?
Yep.
Okay. Okay, so I got it. I got it. Yep, I see it. I see it, Al.
Okay, so and
I see you on the side.
You see me on the side. So that's what's going on in my system.
Okay, so I'm gonna just leave this sit over here. I see everybody else on the side, and I see me.
Are you able to? Can you turn and see if you can hear it? Okay, on the Facebook. Can you turn your volume up to see if you're hearing it?
Oh yeah, I sure can.
You are hearing it. Okay, that's what I'm sure.
Hold on.
Yeah. Testing 1 2 3. Testing 1 2 3. Want to make sure we have sound going out. Okay, good.
You got, yep, it's good. And so when Bill and Clarence are talking, you're gonna put the spotlight on them?
Yeah, I think the Zoom will do that. Yeah, absolutely.
Okay.
Yeah, your Zoom does that.
Okay, so we'll wait a few more minutes.
Okay.
Just wondering if I should swing around because I got two computers trying to go here.
Okay. and so even though we're not formally started yet, we are streaming now on my side, so which is okay because it shows that we're community people and we're doing this work in progress, which is good.
We're having a nice session on learning how to stream this
morning
with Mr. McFarland. How about that?
We're being real.
Well, I know that people are gonna start jumping on. Hello, ladies. Nice to see you. Hi, Ronda, Dr. Ronda. Nice to see you. Are you ready to start, Mr. McFarland?
I am. Hey, Dr. Ronda, how you doing?
I'm fantastic. How are you?
I'm doing well. You probably can't see me on Zoom, but you hear me on Zoom.
But I know that voice.
Yeah, there we go. And I'm actually seeing you and sharing the stream, the Zoom stream, to my StreamYard channel. So we're sending this out to Black Press USA Facebook, Black Press USA YouTube, Insight News Facebook, Insight News YouTube, also Insight News Twitter, and Insight News LinkedIn. So several platforms simultaneously. And, it's wonderful that we're able to use this technology to talk about community.
So how about we get started out? I see people are jumping on. So I'm going to officially call this meeting to order. My name is Diana Hawkins. I'm the Executive Director of the Hawthorne Neighborhood Council / Northside Urban Coalition. I want to welcome you to our September meeting today. We have some fantastic guest speakers that are going to be speaking to you about some real stuff that's happening in the world today. And I am going to bring my good friend and co-host on, Mr. McFarland. You're going to be able to hear him, but you won't be able to see him because he's streamlining us on all these different platforms. But if you turn your Facebook on, you will see yourself when you're talking, and you'll see Al sitting on the side. So with that being said, Mr. McFarland, how are you today?
I'm well. Thank you so much, Diana. And thank you to all my friends and colleagues in community. Welcome to the September meeting of the Northside Urban Coalition. And as Diana said, we're using two technology streams to accomplish this. We're having the meeting on Zoom. So we're with each other in Zoom space. But what I'm also doing is
recording in progress.
This meeting is taking the Zoom feed to my StreamYard platform, and that StreamYard platform is allowing me to share this meeting, this conversation across several platforms, including the YouTube channels of Insight News and the Black Press of America, Black Press USA, including the Facebook pages for Insight News and Black Press USA, and finally, including the Twitter and LinkedIn pages of Insight News. So we are being multimodal, multi-platformed, and why we are sharing our conversations with each other to the world through the use of this wonderful and marvelous technology. And why is that important? It's important because people everywhere are having conversations just like this. And I think to the degree that we recognize how magnificently ordinary our interactions are, we invite others in our neighborhoods and our families and in communities and families like ours around the world to figure out how we can be together for mutual benefit, for clarity, for growth, for development, for the achievement of the kind of society that we value and aspire to create. We enable this sense of authorship. We, in fact, see ourselves and remind ourselves that we are at the table of decision and that we are attempting to write a story. Are you all hearing me okay now or not? Is everybody hearing me? Okay, I think you are. With that, let me move to the agenda. Clarence, are you hearing me okay?
I am. Thank
Okay,
you.
great. I just wanted to make sure. So let me take that. And thank you for allowing me to go long on my introduction. You can tell I love to talk. So look, here's the agenda. We always start with the monthly crime update. Our friend and colleague from the 4th Precinct, Bill Magnuson, is here. Bill, good morning. And would you give us the crime update?
Yes. Good morning, everyone. So for the month of September for Part 1 crimes, and I remind everybody as usual that a Part 1 crime is anytime there's been a victim involved, so it's our more serious ones. We track for the Hawthorne neighborhood for September till today's date. There's been one homicide. Just in case everybody's wondering, that was the one over between 4th Street, over on 4th Street between West Broadway and I think 21st or 22nd Avenue. There was 0 rapes. There's been 3 robberies, 22 aggravated assaults, 3 burglaries, 4 thefts, 14 auto thefts. The big uptick in those are going to be the Hondas and the Kias that we're struggling with, but so is the entire country, basically. I just found out that there's been a lawsuit against Hyundai and Kia regarding these, and 1 arson for a total of 48 Part 1 crimes. Does anybody have any questions?
What happens typically when the weather changes, Bill? We are cool today. School is back in, number one. So theoretically, a lot of younger people are not, they're out there in school. And then the weather kind of slows down some of the movement in the community. What typically happens?
Well, what typically happens, and it's not just with Minneapolis, but St. Paul, Chicago, Milwaukee, what typically happens as we get into the cooler months, and the further we get into the cooler months, so we coming up on November, December, January, February, we're going to see a decrease in crime because of the colder weather. So people aren't going to be less likely to be out and about committing crimes. So therefore, the narcotics sales that sometimes will lead to shootings and other things are going to be tampered down with because it's going to be colder for them to be out there. So I guess for the lack of a better term, old man Winter is probably a better crime prevention specialist than I am.
Okay. Any more questions or comments, more feedback? Okay, great. Well, Bill, thank you so much. Thank you for your service and your leadership. Let's go next to our colleague.
Let me say this one thing.
Sure.
This is for Diana. Diana, just I got confirmation from Inspector Adams that he will be at the Hawthorne Huddle for October if you just want to form the link.
Awesome. Wonderful.
Thank you, everyone.
All right, thank you. Clarence, let's have the update from our Human Partnership.
Well, thank you. I'm always glad to give the updates, and I'm also glad to see so many different and new faces who are a part of this project. But today, I'm asked Dr. Ronda Chacolis. She's going to do the rest of the program for us, and I'm going to turn it over to her.
Good morning. My name is Dr. Ronda Marie Chacolis. It is an honor and privilege to be here with you today. In particular, Mr. McFarland, this is a dream come true. I've seen many of these conversations that you had, and I'm happy to be able to share my expertise here as a pharmacist and a longtime resident in North Minneapolis. Over the past few months, I've had the pleasure and opportunity to work with Human, a partnership, in particular dealing with what we know as the opioid crisis. One thing that we have found is that message in that term opioid sometimes excludes the population who that condition is affecting. So what is an opioid? An opioid stems from opium, but most people, when they hear opioids, don't think that it's our community's problem because they equate opioids with prescription medicines. What we know now is that more than 33% of the opioid overdoses are related to non-prescription medicines, in particular fentanyl, which is synthetic. And those numbers are on the rise. While we see that, the number of prescription opioids that are being dispensed, like your hydrocodone or your Percocet, have dramatically decreased, all while the number of opioid fatal overdoses have increased significantly, as well as the non-fatal overdoses. One thing that's concerning that we've seen out of COVID is that those opioid overdoses are affecting two segments of our populations, in particular, elderly people, as well as younger people. And as we know, African American people and Native American people are more likely to die of an overdose. The beauty of Human Partnership as a clinician is allowing people to connect with best practices and research. Human goes where the people are at. We want to hear from people. We want to hear from our community. And we want to help use their experience to frame our message. And so over the past few months, some of the training that we've been doing is really Narcan training. As a clinician, I participated in many trainings. It was extremely well done. It was done in a culturally specific way, but what stemmed out of that was people wanted to know more. They wanted to know why. They wanted to know how. They wanted to know how to make this message resonate with particular communities, let's say the Somali community or younger people. And so as we've kind of expanded our work, we have had the opportunity to make culturally specific recommendations in partnering even with young people. We're looking at doing innovative ways of meeting people and connecting them in terms of using social media and what have you. And with that, I would like to turn it over to one of Human's newest colleagues, a young lady who is from the University of Minnesota, and her name is Fazia. Go ahead and introduce yourself and tell us more about what you're doing with Human.
Hi, thank you so much, Dr. Chacolas. I am really excited to be here because this is a really important issue, especially in my community. I'm East African, and I've had personal and lived experiences within my family regarding, fentanyl abuse, opioid abuse, just addiction in general. So I've been working with Human to create culturally tailored or relevant workshops, educating the community, interventions that'll provide the community with resources that they need, specifically marginalized communities, as you mentioned, and especially the youth, especially as we're noticing younger individuals are getting into the opioid addiction. So I'm happy to do what I can.
Fazia, put your name in the window if you know how to do that. I don't know if you can look at. Can somebody tell her how to put her name under her where it goes, so we can see your name?
Oh, okay.
You see everybody else's names in the window.
We can see her name. We can see her name.
I can see her name.
Oh, you do it? I don't see it.
Yeah.
Okay. Now I see it, Fazia. Yeah.
Oh,
Fazia Hassan. I see it now. Okay.
It's Faiza.
Great. Thank you
Faiza.
for the presentation. And Rhonda, do you want to bring somebody else in as well, or what?
I believe we were going to be having Suzanne on.
Yeah.
Is she on?
Yeah. Well, let's do this. Let's bring Suzanne. I have like maybe one gazillion and one questions to ask you and Fazia, because what you've done is laid out just a variety of things for us to consider, to weigh in on, and to learn through. So first of all, thank you so much about being present and bringing your knowledge, your wisdom, your leadership, and courageously to this conversation about building community and creating health. That's number one. So let's do this. Let's ask Suzanne Young, who's project manager for in the city of Minneapolis, to talk about data on overdose harm and reduction initiatives. Suzanne? Is Suzanne here? Is she on?
Yeah, she's here, but she
Okay.
has on mute.
Okay.
I'm so sorry about that. Thank you
There
so
we go.
much. And thank you for having me again today. I really appreciate this group and the input that we get from this group to bring forward to our leadership at the health department for informing strategy on this important topic. I just wanted to talk a little bit about, we have Dr. D, we call him, on the line as well. And I'm going to, I've asked him to cover some of the alarming statistics, and we do want to have time for conversation. So I'm going to go rather quickly. And if there's things that you want to know about, please ask any of the panel here. Just a couple updates. We are working on we have been and continue to bolster our initiatives on working on a more cohesive, collaborative response that involves all aspects of community members, also state and county partners. And one of the ways that we're doing that is with the settlement dollars that are coming down from Big Pharma. We'll be receiving approximately $10 million over the course of 18 years. And we did not negotiate that settlement. We had attorneys that were involved in the process, but that was other people, state, federal folks that negotiated those settlements and how they're going to be dispersed. So we'll approximately get $400,000 to $500,000 a year for 18 years or 14 years. There's a little bit of discrepancy on how that's coming down, but as soon as I get the final word, I just wanted to put that out there because there is some talk about that. And I know that it sounds like a lot of money, $10 million, but over that course of a long period, it's not really a ton. But there are some smaller settlements that are coming on from other companies that will help get us started right away. So we expect to have 3 to 4 payments rather than just one payment this coming year. So once we get that information in, I'll share it out to community because we want to operate with the most level of transparency on that. And then we are working with Hennepin County and other cities and cities within Hennepin County to put our best practices together. Each community is very different within the city, as you all know. So each cultural group, each area needs an approach that's well thought out, and we're trying to maximize our resources by working with our county partners in a way that we haven't worked before, which I'm very, I think is a very positive move because this is a huge mammoth problem, and everybody does their part. Everybody here does their part and has something to offer and contribute. So we're working from that strength-based approach. I want to highlight 2 initiatives that we have going on right now that you may be of interest, and Human and partners have been involved with. Is the mobile health unit that we have going out to address access to medical assisted therapy. What we found is that over the past couple of years, we've done a really good job of getting doctors educated on medical assisted therapies, and it's a ever changing process, and people are learning in at different levels of the spectrum and understanding on how those medications work and how to best prescribe those medications to people in the community. Our target populations, the highest affected, are not accessing MAT. And so we're looking at strategies to address that. And one of them is the mobile unit. So it's going out and getting access to structured medical assisted therapy, and then creating pipelines to long-term recovery. So we've really shifted our focus at the city from heavy harm reduction to treatment focus, and how do we reach people and bridge those gaps of service delivery to the people in most need. And then part of that initiative is our First Step initiative, which is medication first. And I'll have Dr. D, he really does a great job of explaining the importance of that with our target population. The fentanyl is a fast acting, highly addictive drug. And people need assistance in getting off of that medication, off of that drug. And then they also need a safe place to go through that process. So we're looking at how can we access what we already have in the community to give supports for people that want to go through the medical therapeutic induction, because it's quite a process, and sometimes people don't want to do that when they're around their family or in crowded homes, or if they don't have a home, if they're unsheltered or homeless, having a spot for them to go be safe and comfortable through that process. So those are some of the things that we're looking at right now. And we just put an RFP out for the First Step model, and are in the process of contracting that out right now. And I'll let Dr. D go because he has a lot of great information, and then we can have a discussion. I want to leave time for a discussion because I have been to a lot of these community meetings lately, and it seems like the community discussion piece gets cut short, and I don't want to do that here. So I'll move on to Dr. D. Thank you.
Well, first of all, thank you for your excellent introduction and presentation. So yes, please.
Hi, good morning. Thank you. I will try and keep my comments brief and more in update form from the last time I was able to join this conversation a few months ago. I've learned a lot since then. I think we as a community of health professionals and health systems have learned a lot about this evolving epidemic and the issues with fentanyl in particular. Fentanyl being very different from prescription drugs, oxycodone being very different from heroin. I think, some of the comments from our pharmacy colleague early on talked about the synthetic opioids. The potency of fentanyl has more of an effect on the brain, where it becomes more difficult to treat with medications. And so that's the main point that I want to get across. Efforts at harm reduction or efforts at abstinence only approaches to dealing with the opioid crisis, with the fentanyl crisis, for those reasons, do more harm than good. So if we're failing to understand that what's essentially now a fentanyl crisis is a medical disease, then we're just missing the boat and we're not going to turn this thing around. It's a medical disease because of the effect this potent chemical has on the brain. So when I see patients come into the emergency room, like just last night, I need to give them medication, just like a diabetic will need insulin to replace the hormone that their pancreas normally makes. Our opiate using patients need medication to stabilize their condition, right? And that stabilization means they're having cravings, they're having withdrawal symptoms. So they need medication to get stabilized before you start having conversations about accessing, more broader forms of treatment, which is the therapy, the either one-on-one therapy or the group therapy. Other elements of treatment include financial assistance. A lot of times the Rule 25, the medical assistance that's needed for these patients to go from active daily use to leading a normal life and long-term recovery, there's a big financial barrier there as well. But if I'm an opioid user and I have 12 to 24 hours before my cravings start kicking in, there's no way I'm going to get organized to start making appointments with an addiction clinic or with a social worker, because I'm going to have those cravings, and then I'm going to go out back on the street and self-medicate the best way I know how. So that's what we're seeing with fentanyl patients. I had some slides prepared, but I want to defer to the group discussion and Q&A, but just by matter of brief update.
No, I think you can take the share the screen and run the slides. That'll be fine.
Okay.
Yeah, Diane, can we give him access to screen share?
Let me just make sure I have.
Yeah, let's go
There,
through
can
it.
everyone see my screen?
Yeah.
Okay. So these are data up until 2019. I think we're familiar with this. Native American populations seeing a 7-to-1 death disparity compared to white populations. Black Americans 2-to-1. Just since 2019, those new numbers, if I remember this correctly, Native Americans have jumped from 7-to-1 to 12-to-1 in Minnesota. And for Black Americans, it's 2-to-1 to 3-to-1. And I make that comparison because this is not explained by different patterns of use. This is explained by access to treatment or engagement with treatment. So we're not, as a health provider, I'm not doing a good job of getting the medication to these heavily affected populations. And that's a big focus of some of the programming that Suzanne talked about. So we're seeing this nationwide. It's not just Minnesota, although Minnesota is one of the more highly affected. In 2020, a significant year, we saw the highest rate of increase amongst Black Americans. For the first time I'm aware of, exceeding the rate of increase. So 2020 was a bigger year of deaths in the Black community, or rates of death rather, than in the Native American community. It was a big year for everybody in terms of growing opioid problem. But these are some of the dynamics that we're seeing. On top of that, counties with the highest rates of income inequality. So I think Hennepin County is in the 86th percentile in terms of income inequality across the country. Those counties saw even higher rates of increase. So as a Black man in Hennepin County, I have 2 times the chance of dying from opiate overdose as, say, compared to a county in Maryland or out east where they have lower differences in income inequality. Another finding from this nationwide CDC report is that even in areas where there is potential treatment access, so there's people, docs like me, who can prescribe the medications, we're still, that's not just because we have the potential for prescribers doesn't mean that people are engaging in the care or that we're reaching the people that need it. And I think that's because, you know, our models of care are geared toward, we do a great job with, you know, the Hazelden crowd. We do a great job with people with financial means. You know, if you are Prince, for example, or, you know, someone who's wealthy, then you have a much easier path navigating the system than some of our unhoused folks. So the takeaway for that is we are working on more culturally responsive care. We're working on, you know, there's all types of reasons to explain that. Trust being a huge one. And I think that the answer to that trust deficit, the answer to that lack of engagement really starts at the community level, understanding, educating, and then helping the health system, helping the docs do a better job of filling that gap. I'll skip through some of the reasons why fentanyl is so toxic. In terms of terminology, you know, we hear treatment and harm reduction and prevention as the three main buckets of approaches to solving the fentanyl crisis, but they're also interlinked. And the beauty of the medication, Suboxone or buprenorphine, is it's not only essential in treatment, but it also helps prevent overdoses. So it's covers both harm reduction and prevention. When it comes to the treatment benefit, this data shows the rates at which people die in the population. So the green bar on top shows an expected rate of death for the population. The red bar in the middle shows the rates of death in the opiate using population who don't have treatment, who don't have that medication. You can see that's 6 times a higher risk. And this data is from 10 years ago, maybe 5-10 years ago. So all those increases that we're talking about in the last few years, that red bar is all the more pronounced compared to the general population. And then the blue bar on bottom is the rate of death amongst opiate using populations who are on the medication, on Suboxone or on methadone. And it's a significant 300%, right? 6 to 1 compared to 2 to 1. It's a huge, huge benefit for keeping people alive and engaged in care. And as a medical system, this drug has been around for 20 years. We're just now in this country anyway, figuring out how to use it to meet the needs of our patients. And some of that is, you know, our own stigma as health providers towards patients. Up until 5 years ago, I didn't understand that opiate use disorder was a medical disease. I thought it was more, you know, behavior or lifestyle choice. If someone came into the ER after getting Narcan rescue from an overdose, and the first thing they want to do is go back out and use again, I was overly judgmental with these patients. And, you know, I would try and have a conversation saying, you just dodged a bullet, you were almost dead, now you're not dead. You know, it's kind of condescending, but it was my lack of understanding that that's a normal expected response. This is someone who's having medical withdrawal symptoms. And of course they want to go self-medicate. It was my job to give them the medication to treat their withdrawal. But I just didn't know. I think we as a profession, we're slow to understand that. We're getting better now. We're fixing that. And I would say just really for myself in the last couple of years, and it seems like every month I learned something new. So I'll
D-
just
Dr. Ntaba, let me jump in and ask you a question, because I think
Yeah.
this is a great place to look at the value society places on different people's experience in life. So the question is, you said in the past 5 years, you became more aware of how you looked at and interpreted the behavior or the medicine of the challenges being presented by patients, customers.
Yeah.
Has the society shifted in growing a different understanding and awareness? And if it has, what has motivated it? The